the most common solid cancer of childhood is? Do you know what the most common frequent malignancy of infants is?
What is one of the most aggressive and difficult to cure childhood cancer? Can you think about an almost exclusively pediatric cancer?
Can you think about an almost exclusively pediatric cancer? Can you tell me one of the few cancers which secrete hormones? Have you ever heard of neuroblastoma? Hello, my name is Blas and this is Michelle and this is Nada. We're Bachelor of Nursing students at Swinburne University, and in this presentation we're going to talk about a very little known pediatric cancer called neuroblastoma.
First, we're going to answer some questions you may be wondering about this cancer, and after that, through a case scenario, we'll discuss
the clinical manifestations, diagnostic tests, pathophysiology, treatment, nursing management, and potential complications.
We hope you learn a lot and enjoy our presentation. Please
Let's
keep on watching.
watching. When many people hear about neuroblastoma, they only think about brain cancer. Neuroblastoma is a solid tumor cancer of the sympathetic nervous system. When we talk about solid tumor, we mean a mass or lump. This mass originates in the neural crest tissue, part of the sympathetic nervous system. When we talk about the sympathetic nervous system, we refer to the part of the nervous system responsible for the fight or flight response. Neuro indicate origin in nerve cells. Blast mean immature cells. The oma ending means tumor. Therefore, neuroblastoma is a tumor caused by immature nerve cells. Normal neuroblasts or baby nerve cells begin in embryonic tissue and grow and mature into functioning nerve cells. Neuroblastoma means the immature nerve cells reproduce, forming a mass, and do not develop into functioning nerve cells. Neuroblastoma is considered a rare disease. Most GPs and pediatricians will never see a case during their careers. About 40 children are diagnosed with neuroblastoma in Australia every year. There is a chance of 1 in 100,000 of a child suffering neuroblastoma. The incidence is a bit higher in boys, 55% of the cases compared with 45% in girls. 90% of the patients are younger than 5 years old, and the median age at diagnosis is 22 months. The number of diagnoses decreases as age increases. Adult cases are extremely rare, accounting for less than 2%. There is a similar incidence in other countries and no clear differences between ethnic groups.
The cause as to why this cancer occurs is unknown, as there are not clear environmental links. However, scientists believe it is due to an accidental cell growth that takes place during the normal development of the sympathetic nervous system. There are a few cases, 1 to 2% of the diagnosis, where neuroblastoma runs in the families due to a particular genetic mutation called AKL, also known as anaplastic lymphoma kinase. Nonetheless, it is the most of the cases there is no known genetic cause.
The most common place for neuroblastoma to develop is in the adrenal glands. This happens in 40% of the patients. It may also originate in nerve tissue in the abdomen, 30% of the cases, chest, 19%, pelvis and neck in 1% of the cases, and anywhere along the sympathetic nervous system.
Children with neuroblastoma present with a wide range of symptoms which are common to other non-serious childhood diseases, like low-grade fever, irritability or joint pain. Symptoms depend on where the tumour originates and if it is spread. Often they're not obvious until the cancer is big enough. If the tumour is in the abdomen, the child may have a swollen abdomen, constipation, vomiting or diarrhoea. When the tumour is in the spine, the patient may stop crawling or walking, may have weakness or paralysis. Breathing difficulties may be experienced if the neuroblastoma originates in the chest.
A neuroblastoma in the neck may cause Horner syndrome, a rare condition caused by damage to the sympathetic nerves in the face and whose main signs and symptoms are constriction of the pupil, miosis, drooping of the upper eyelid, ptosis, and absence of sweating in the face. When the disease spreads to the bones, the child may have periorbital ecchymosis, what is called raccoon eyes, as a consequence of a fracture at the base of the skull, leaking fluid and blood into the tissues around the eyes. As well as a consequence of the spread of the cancer to the bones, the child will experience bone pain, bruises, paleness, and may limp or stop crawling and walking. And in very rare occasions, there is an autoimmune reaction to the neuroblastoma cells called opsoclonus myoclonus syndrome. Antibiotics will react against cells in cerebellum, and as a result, the child will present with jerking, rapid involuntary eye movement, and muscle ataxia.
As it was mentioned before, it is a rare disease that GPs and pediatricians may not be familiar with, which makes it hard to diagnose as the symptoms mimic other non-serious childhood illnesses. Neuroblastoma, acute leukemia, Ewig's sarcoma, Wilms tumor, rhabdomyosarcoma look identical under a microscope as several small round blue tumors as they lack cytoplasm and have a large blue nuclei. Therefore, a definite diagnosis will be made from the result of a biopsy from the primary tumor or metastases, along with high levels of catecholamines in the urine.
According to the International Neuroblastoma Staging System, there are 4 stages. Stage 1 is when the tumour is located in one area and can be removed through surgery. Stage 2 can be divided into Stage 2A, where the tumour is confined to a specific area but cannot be removed surgically due to size, location, or proximity to vital organs. Lymph nodes are negative for neuroblastoma. Stage 2B. The difference with Stage 2A is that lymph nodes on the same side of the body where the tumour is located are positive for neuroblastoma.
Stage 3, there's 3 situations. A. Tumour infiltrates across the midline of the body, that is the spine, with or without lymph node involvement. B. Tumour is confined to one side of the body and the lymph nodes on the other side are affected. C. Tumour crosses the midline of the body and lymph nodes on both sides are infiltrated.
Stage 4. Primary tumor with dissemination to distant lymph node, bone marrow, bones, liver, skin, and other organs. Within Stage 4, there is a Stage 4S, where the tumor is localized like in Stages 1 and 2, but the disease has spread only to skin, liver, and less than 10% of the bone marrow.
During a routine checkup, the local pediatrician detects a firm, fixed, palpable mass in the upper right quadrant of Eddie's abdomen. Until that moment, the infant had a normal development and had no presentation of any signs and symptoms. A CT scan reveals a solid mass of 7.5 centimeters in length. 8.2 centimeters in width and 8 centimeters in height, originating from the adrenal glands. Following tests did not show the presence of metastasis and confirm the diagnosis of neuroblastoma. The tumor is well located, so it was surgically removed. No post-op complications.
Eddie Wilson is a 34-month-old Caucasian boy who has just been admitted to the paediatric oncology ward to start urgent treatment for relapse of neuroblastoma. Eddie lives with his parents Christine and Sam in Port Fairy. His father is a metal worker and his mother is a high school teacher. He hasn't got any siblings. Christine has been Eddie's full-time carer since Eddie was diagnosed with neuroblastoma for the first time when he was 7 months old. Christine took Eddie to her local paediatrician a month and a half ago, concerned about Eddie's lack of appetite, lethargy, irritability, constant complaints about pain, and above all because Eddie first stopped walking, then crawling. When she tried to make him stand up, Eddie would commence to cry. The paediatrician, taking into account his previous history, referred him to an oncology paediatrician in Melbourne who initiated the tests, which confirmed a diagnosis of neuroblastoma stage 4.
On admission, his vital signs were blood pressure 135/80, heart rate 140, respiration rate 28, and oxygen saturation 98%. He has mild fever 38.2 degrees centigrade. A paraspinal mass, confirmed as neuroblastoma, is compressing from T7 to T12. As a result, Eddie has lost the mobility of his lower limbs. He presents with urinary retention and constipation. He is irritable, crying constantly when he is moved and complaining about pain. A neuroblastoma is a tumor composed of immature nerve cells or neuroblasts, more specifically of human embryo neural crest cells. Neural crest cells originate in the neural tube and from the 5th week of the fetus development start to migrate along the spine. They are stem cells with the potential to become a large number of differentiated cells depending on where they go and settle. They can develop into neurons and glial cells of the sensory, sympathetic and parasympathetic nervous system. They can develop as well into pigment-containing cells in the epidermis, into epinephrine-producing cells of the adrenal gland, and many others of the skeletal and connective tissue of the head. The cause of neuroblastoma is unknown, although there have been research on intrauterine exposure to alcohol, certain medication, or hair dye, without finding clear evidence. Nonetheless, scientists believe it happened during the development of the sympathetic nervous system in the fetus. Neural crest cells fail to become mature nerve cells and adrenal medulla cells, and instead continue to grow and divide, forming tumors. The sympathetic nervous system connects the brain and the central nervous system to different organs, and under a stressful situation commence the fight and flight response by releasing certain hormones. Sympathetic neurons produce noradrenaline, and adrenal medulla cells produce adrenaline. These hormones, when no longer needed, break down into metabolite, homovanillic acid, HMA, and vanillmandelic acid, VMA. These metabolites are found in the blood and urine and are very important to the diagnosis of neuroblastoma, because neuroblast cells, although failing to become fully mature cells, produce sympathetic hormones and consequently metabolites. Neuroblastoma has been associated with the mutation in oncogenes and tumor suppressor genes. Oncogenes help cells grow and proliferate. In neuroblastoma, amplification of the MYCN oncogene is a predictor of rapid tumor progression and poor outcomes. Tumor suppressor genes slow down cell growth and proliferation. Deletion of chromosomes 1 and 11 or anaplastic lymphoma kinase ALK in neuroblastomas cause the tumor to grow without control. To sum up, amplification of oncogenes and/or deletion of tumor suppressor genes are responsible for the uncontrolled neuroblastoma growth. As a result of the development of the tumor, cells from surrounding tissues in lymph nodes, liver, bones, and especially in the bone marrow will start to release chemokines, particularly CXCL12. Chemokines are signaling proteins which will induce the inflammatory response by recruiting cells of the immune system to the site, causing the non-specific neuroblastoma symptoms like fever, fatigue, weight loss, or sweating. Unfortunately, chemokine CXCL12 will attract neuroblastic tumor cells. In the case of a cell which break away from the tumor and get into the blood or lymph, it will tend to migrate to organ or tissues where chemokine is produced. This explains the common places of metastasis for neuroblastoma.
The first nursing management we're going to do is risk of skin breakdown due to sacral spine compression and decreased circulation leading to tissue damage, with the use of repositioning to reduce pressure on one area for an extended period. We'll use things like a pressure mattress, placing the child on alternate sides using small pillows to take off the full pressure, especially on the back of Eddie's head. We'll do the repositioning of Eddie every 2 to 4 hours. This is to minimise skin breakdown and prevent pressure sores. Skin breakdown is caused by decreased sensation, inadequate nutrition, and shearing from sheets or equipment. Young children also have thinner dermal layers. Positioning can reduce pain using a non-pharmacological method.
The second nursing management intervention is inadequate nutrition causing weight loss, nausea, and loss of appetite due to radiation and chemotherapy treatment. We will do this by using an NGT tube if intake is inadequate. And the way we'll be doing this is by measuring the tube from the tip to nose to ear to middle chest. So we'll place the child in a supine position, slightly tilting the nose upwards, lubricate the tube with a lubricant or sterile water, and insert it into the nose, tilting the tube back towards the occupant. Placement can be confirmed using lip knits paper for pH levels, attach tube to cheek or forehead with tape and mark the placement. Arrange X-ray to check the placement of the tube. And we will be doing this frequently and monitoring Eddie's daily weight and ensure that there's a strict fluid balance chart and it's charted on every meal. Following that, we will also make sure the NGT regime is charted as well. And we'll check the placement of the tube before each feed and also medication. And the rationale behind this is to provide adequate nutrition for Eddie, reducing the chance of anorexia.
The third nursing management is to reduce the risk of infection from a CVC and compromised immune system from treatment. We'll be doing this by implementing CVC care and infection risk. This will be done by monitoring his temperature every 2 hours for fever, ensuring that infection procedures are adhered to, with families and visitors also being educated. The use of good hand washing techniques and that all visitors are free from illness to protect Eddie's lowered immune system before they enter the room, and to administer antibiotics as per a medication chart, requesting it from the doctor if it's not ordered. Along with temperature checks, regular vital signs and skin checks would be done 2 hourly, twice a day assessment of head to toe assessments, and CVC dressing changes every 5 to 7 days, unless needed PRN. The aim of this is to prevent infection and sepsis. The fourth nursing management is to manage Eddie's pain related to compression of the spine and post-treatment. This is for pain management. We're going to use subjective and objective data to assess Eddie's pain level and tolerance, using the FACES pain scale or Wong's-Baker pain scale, indicating level of stress, pain level and tolerance. The nurse needs to be aware of signs and symptoms of septic shock. This will be done by administering pain medication as charted regularly over a 24-hour period, noting if any additional analgesia is required for breakthrough pain. We'll assess Eddie's pain with every vital sign check and post-medication administration to ensure that the pain medication regime is adequate. We're doing this to manage and reduce Eddie's pain using a therapeutic regime and to minimise breakthrough pain and provide pain relief. The final nursing management we're going to discuss is to manage Eddie's nausea and vomiting post-treatment. This is to reduce the symptoms of nausea and vomiting by using continuous antiemetics, monitoring the type and amount of vomit using the fluid balance chart. The frequency is to use continuous antiemetics as charted. This is being done to reduce nausea and vomiting that can lead to malnutrition and dehydration, reduced electrolyte imbalances, and assist in the patient's oral nutrition intake.